That's why you will see here a patient being transferred by express boat, carried in such unprotected condition. Please make sure you do not fall, or you will face this. This is another trauma in Sarawak, and my friend, it is not uncommon. But these patients always receive immediate intervention and are we as medical providers giving timely definitive care. With a conjoined team of experts forming a trauma team leads to a better outcome of our polytrauma patients. And today, I am standing in front of all of you to present 2 polytrauma patients that presented to our emergency department. 46-year-old gentleman, riding a motorcycle, he skidded and knocked into a stationary man. Upon arrival in our ED, primary survey was done. ABC were all clear. However, his GCS was 40, with pupils equal bilaterally. A CT brain was ordered and proceeded. It came back to be normal. He was then referred to the orthopedic team for close fracture of left tibia and fibula. A continuous bladder drainage was ordered by them, but we noted there was hematuria during insertion. After discussion with the surgical team, a CT rogram was done to rule out bladder injury. During our handover rounds, we noted that the patient had a wider media spina with bilateral lung contusion and wrist fracture on the chest X-ray. Therefore, the third CT was ordered, which was the CT angiogram. This patient was pushed in and out of the CT, and he was stranded for 8 hours. But he was transferred out to a tertiary center for further care eventually. Here I am to confess that we didn't see the patient as a whole, and 3 different CT imagings were done and ordered separately for the same patient in the same visit by 3 different disciplines. We clearly have missed it. A trauma patient stranded in ED for 8 hours just for this. It is clearly not an excuse. The second case that I want to share with all of you is patient B. He was a 22-year-old gentleman brought in by our pre-hospital care team. Helmeted motorcyclist was found by the roadside. He was drunk and mechanism of injury was unsure. We noted that his BP was lowish. He was tachycardic. His pelvic swing was positive. There were no other source of bleeding. Multiple fast scan was done, but it was also negative. We resuscitated him with fluid with blood transfusion. Refer him to the surgery and orthopedic teams to rule out retroperitoneal or bowel injury and pelvic fracture to rule out vessel injury. He was reviewed by the orthopedic team with the impression of left superior and inferior pubic rami fracture, unlikely vessel injury, and he was planned for conservative management. He was also reviewed by our surgical colleagues, which they had an impression that they were unable to rule out abdominal injury. They suggested to us to stabilize and send for CT abdomen. We actually bought into that idea and continued to resuscitate the patient with blood transfusion, but the BP just couldn't pick up. Thankfully, we have an EP, and she discussed this with the surgeon on call. The surgeon agreed to go to OT for emergency laparoscopy. He found out there was an extensive retroperitoneal hematoma with oozing of blood, and there was active bleeding from the pelvic floor muscle. I'm here to confess that clearly this patient is hemodynamically unstable, and he needs damage control surgery due to the inadequate basic knowledge or concept of trauma by both the ED team and the primary team. We initially that is why this patient was stranded even though he didn't go into OT. This, my friend, is just the tip of the iceberg of the challenges we face in ED. What are the possible root causes? Karl Popper, a famous Austrian-British philosopher, actually said that true ignorance is not the absence of knowledge, but the refusal to acquire it. We refuse to be ignorant, and that is why I am standing here to confess and to learn from our mistakes. Are we stuck in our comfort zone? There are some teachings which have been passed on for generations without any outbreaks, and we feel comfortable because he did it before, and we never dare to step up and challenge its authenticity. We, I believe, need a common language in managing trauma patients effectively to prevent delays in explaining and convincing. That is why I truly believe that we need a trauma team in Sarawak. Hospital. But today, I hope that there will be the birth of a trauma team, which I believe is the workable concept. Let me explain to you that the trauma team is a multidisciplinary group of individuals from different expertise, comprising from the anesthesia, emergency, surgery, nursing, and even our supporting staff, where we will give simultaneous inputs and assessment and management of the trauma patient, which is coordinated by a team leader. The objective of this trauma team is to identify life-threatening injuries and prompt for immediate interventions. Many literature reviews and surveys have shown that the trauma team has shown to reduce overall trauma mortality rates from 6% to 4.1%. The concept reduces time from ED arrival to CT scan, OT, and even to ED discharge. Who can set and be the trauma team leader? The leader is usually an emergency physician or a surgeon. Agreeably, operative interventions are often necessary, thus a surgeon should lead. But we believe that a trauma team can be set up even in a district setting, and it is more important to have a leader trained in trauma management with the appropriate experience. Now, there is an idea. How do we take it from here? There are many trauma life support courses out there, and one of them is ATRS and TRS, which can adequately train us to proper trauma management. And I'm sure all these life support courses actually helps and train each individual to speak the same trauma language, as it is a well-trained systematic approach for the assessment of trauma patients. Apart from that, we should always upgrade ourselves with the latest guidelines with continuous medical education. Regular simulators such as interactive trauma modules and decision scenarios have also been effective, as they actually give the participants to be exposed to life-threatening conditions which are raised under a very controlled environment with a trauma team. Thank you.
I know that most of us dream about trauma team in most hospitals. Yeah? But I think thank you for coming up. It's a very complicated problem, discipline problem. Okay? And some people, not us, some people they are quite comfortable with what they're doing now. They don't want to do extra work. Probably, I see. So, is there anybody want to share their experience? I think some of us will already come up with this trauma team challenge or how is someone doing it? Anybody? Prof. David, comment anything?
Well, trauma is the #1 cause of death in undeveloped and developing world. It's the number always in the top 5 or 6 causes of death in the whole world, and it's on the rise. And most of the causes of death that we can expect to happen in the next 10 or 15 years are going to be related not just to trauma, but to car collisions themselves. So if you're not comfortable treating trauma patients, you're going to learn today, because that's your future for the next 15 or 20 years. There are a lot of different trauma training courses, trauma training, trauma systems, and trauma center designation have all been shown not only to decrease mortality for trauma patients, but they also decrease morbidity for trauma patients. And having trauma center training and designation helps non-trauma patients because it helps build a system for rapid evaluation, rapid response, rapid treatment. And the non-trauma patients who are seen in trauma centers actually have better morbidity and mortality than people who are in medical patients who are in non-trauma centers. So there's a lot of good reason to start trauma training, trauma system and center designation, and all the different aspects of that. It should be towards the top of the priority list of every Minister of Health in underdeveloping and developing countries, and anywhere there are roads like that.
Thank you.
Thank you, Dr. Sarikei, for bringing up this question. I think I've been in this business for longer than all of you put together, and I'm still waiting for the dream to happen. Right? If you expect the centers to be there, forget about it. Right? So therefore, at the next level, the important thing is something is that early, can make some sort of decision, and give something that we can do early for this patient. Even as so-called stated as the trauma team is just proposed. Half the time, only part of the team comes. But then somebody comes. Right? And those are the days, if you don't activate it, you don't come. So then we just say, we just call operator, the operator is the trauma team, trauma team coordinate, and operator got everybody in the list. Most of the time, they come residently. Some of the time, the whole team comes. Most of the time, half the team comes. But at least they come. So don't expect evidence-based trauma team. Probably if they get access to come in, work on somebody, on the members of the medical officers, not at your level. Right? Sarikei has only one emergency physician, so can't be there all the time to do that. Even in my hospital, even if you have 24 hours, 24/7, then the emergency physician can come there and take over the trauma team leadership. But most of the time, you can't. So you have to take team leadership, find some way to activate everybody at the same time, and operate is the best. Thank you very much.
Okay. Any last comment before we okay. People say